So, good morning to one and all. I am Dr. Kamalesh, Assistant Professor in the Department of Pediatrics, Chettinad Hospital and Research Institute. So, today we will be talking about the pediatric sleep-related disorders. Let's proceed with the topic. So, today's objectives will be understanding the normal sleep pattern in the children, then followed by sleep assessment in the children, how to do a common sleep assessment in the children, and followed by review common pediatric sleep related problems, and also discussing the treatment options along with the sleep related disorders in children. So, let's proceed. Let's first understand what is the sleep pattern or physiology in children. Sleep, let's take sleep. Sleep is a state of unconsciousness in which the brain is relatively more responsive to the internal than external stimuli, which is an higher mental function, which is mainly done with the help of limbic system in the brain. And also the main function of the sleep is to restore the normal function of the body and also to maintain the homeostasis. So let's go on to the basics. Sleep physiology. Sleep consists of two types of sleep, that is REM and non-REM, that is rapid eye movement sleep and non-rapid eye movement sleep. In REM sleep, there are again 4 stages followed by non-REM sleep, that is stage 1 to stage 4, and the slow wave sleep or the deep sleep pattern occurs from the third wave of the REM sleep, which is followed by non-REM. So REM is what something daydreaming or dreaming. Okay, so the children and the adults usually have a very different type of sleep patterns. They are not similar because in infancy the cycles is 50 minutes. Each sleep cycle will be around 50 minutes. But in case of adult it is around 100 minutes. Okay, so the initially 50% of the sleep in children is REM pattern. Okay, that is rapid eye movement sleep. While in case of adulthood, it is always REM followed by non-REM. Only 25% of the sleep pattern will be REM followed by a brief period of non-REM. So the brief transition occurs in the childhood. So 50% of the sleep in infancy is REM pattern, with non-REM mostly a slow wave pattern which occurs from the stage 3. Okay, in childhood the non-REM gradually increases with the REM. Okay, where the REM gradually decreases with a slow wave sleep pattern, and in adulthood it is predominantly slow wave sleep which gets dropped 40 to 50%, that is non-REM pattern will be the predominant pattern and 25% will be the REM pattern. So and also see the adult, the mandatory sleep period would be around 8 to 10 hours, but in children and infants it varies according to the age. So let's go on with the infants, which is usually who sleeps more than us, that is 12 to 16 hours including the daytime and night naps. Okay, and when in case of toddlers, that is 1 to 5 years of age predominantly, so they will be sleeping around 11 to 14 hours, that is including the day and night time naps, in between naps. And 3 to 5 years old children, usually they sleep around 10 to 13 hours including the naps. And 6 to 12 years old children, it is around 9 to 12 years. Okay, and teens, that is mostly the adolescent period and almost they are young, they will be sleeping around 8 to 10 hours. Okay, and this graph which is depicting here shows the hours of sleep in the x-axis and the age in the y-axis. So let's move on how the children's sleep pattern differs from the adults. Mostly the first point is to emphasize is more frequent of REM in children, while in case of adults it's non-REM. Okay, and the REM will be earlier in case of children when in case of adults. Okay, and more total hours of sleep, that is total duration of sleep is also more when compared to the adults. And the sleep related disorders is more common in pediatric than adults, because the studies which have done in the foreign has showed that the prevalence is more common in the children than in the adults because of the developing because of obesity and also due to food habits, and also the sleep pattern, also the screen time also causes predominant problems in children. So they have more predominant sleep disorders when compared to that in adults. Okay, so and when compared to hours by age, the children needs a greater amount of sleep per day when compared to adults for their maintaining their normal homeostasis or the physiological function of the body. Okay, so a newborn spends most of the half of its sleep in REM pattern and also to maintain its normal function. Okay, so by 5 years of age the change occurs in case of children. Okay, the pattern changes from REM to non-REM. So let's move on to the sleep assessment in children. In all the cases, when we go for assessment, the approach is important. So the approach is predominantly by taking, most of the problems will be solved with the history taking itself. So in children also, the sleep history is very important. We have to ask the parents in all the possible ways, from right from the bedtime and before going to the bed, what are the things the children is able to do before going to sleep. So the sleep history is very important, and it should be from the parents, not from the caretakers. And nowadays we can also rely on caretakers because most of the parents are working, so they caretakers put their children to sleep. So caretaker history is also important. And also after that, after history taking, you have to give a sleep questionnaire. So the parent, we can assess the parents and also the children for their sleep, and based on the scoring we can classify the disorders also. And another thing, we can ask the parents to give a sleep diary to the children, or we can give the sleep diary to the parents itself, so that they can maintain the sleep record of the individual children and they can bring back to us, so that we can assess based on the sleep diary findings also. And screening is a basic, that is also a type of questionnaire, or using some instruments we can assess the sleep pattern of the children. Okay, for example, we can use some devices like Apple watches or actigraphy devices to monitor the sleep patterns and awakenings in the children. And in further, if you find anything relevant in that, you can go for a set of investigations like video recording of the child during sleep, that is 24 hours video recording, then EEG followed by polysomnography, and EMG, that is electromyogram. Okay, that is to assess the limb movements. Based on the limb movements, we can assess the sleep awakenings in the children also. So now we'll go on with the proceeding with the history. Okay, so history is very important in case of sleep disorders also. So first we'll see what are the things to ask in the parents. First is predominant chief complaints. The predominant chief complaints is difficulty in initiating or maintaining sleep in children. Okay, so most of the parents will say that I can't make my child sleep. So what can we do, doctor? So most of the times this is the predominant complaints, followed by excessive sleepiness during the daytime. Okay, the child is sleeping in the school, the teachers are complaining, the parents are bringing the child with the predominant complaints of this also. And also poor academic performance. Again, another one is snoring. Snoring is one of the important cause for the sleep related disorders, that is obstructive sleep apnea, which is one of the predominant problems which has the major symptom of snoring. Okay, and other breathing related problems like apneas, mixed apneas. Okay, and abnormal movements or behaviors before or after sleep. Okay, that is periodic limb movements, restless leg syndrome, which is predominantly seen in children rather than adults. Okay, and additional sleep history, what are the things you can ask is, one is the sleep wake cycle. How the child sleeps during the night? Does the child require any external stimuli or light stimuli or sound stimuli? Like some children will sleep with only with the music, some children only sleeps after giving the mobile phone, some children only sleeps after switching on the light. So it is very much important that sleep wake schedule should be mandatorily known. And the sleep wake schedule, that is, we should know the starting time of the child to going for sleep till the end time, that is the child wakes up in the morning. Okay, the duration is very important, and also the frequency of the problem and temporal profile of the onset, that is abrupt onset of sleep or gradual onset of sleep or intermittent type of sleep, or the degree of variability from night to night, that my child sleeps only from 9 to 1, that is the variability, and from 1 to 3 the child is very active, and next day the child sleeps from 10 to 2, and remaining 3 the child is remaining active. So this intermittent variability is very much important in assessing the history of the child. And also the interventions, what are strategies the parents following to make the child again go for the sleep, that is any medication they are using, or mobile phones, or any other source of stimuli like giving toys, or giving some iPads, or giving some extracurricular activities to make the child sleep. Like some children will like reading, so that they go for frequent sleeping. So some parents make them read before, so that the child goes for sleeping early. Okay, and sometimes you have to ask also the daytime symptoms and the school symptoms, that is the child is whether sleeping in the school, or whether he is having a good academic performance, or whether the child is having a, what to say, inattentiveness in the class, or he's keep on missing the classes and he is irritable in the classes. Okay, these are the additional sleep history you have to ask from the parents or from the teachers. Next, what are the risk factors? Predominantly, we can assess the risk factors based on the history itself. One is the bedtime routine. Next is stimulating activities like mobile phones, televisions, then tablets or cell phones or video games in the bedroom. Nowadays, Xbox and PlayStations have become more frequent in children that they play and only go to sleep. Next is how is the parents making them sleep, whether the parents are lying down along with them or the caregiver is lying along with the child to make them sleep, or they are singing any rhymes or songs, or whether any other sibling is sleeping with the predominant child who is having the complaints, or any other environmental circumstances which is unsafe or which is loud, making the child inappropriate for sleeping, or increased inattention or increased attention towards the response of the caregiver to the child's stalling behavior at the bedtime. That is whether the child is behaving good with the caregiver or with the parent during the bedtime. That is also an important risk factor for further deterioration of the child's sleep problems. Okay, so next we move on to pre-sleep activities. This is what the child does before going to sleep. The period of exercise, that is competitive sports or sedentary activity, which is the one of the main problems leading to obesity, leading to sleep related disorders, more common in children. One study suggests that the inactive child or the physical activity reduces the sleep latency, while the sedentary activity during the day is always associated with increased sleep latency in the day. Okay, and use of electronic devices such as mobile phones, social media, which is more important contributors nowadays to the sleep related problems or delayed sleep in children. And also the family time, the quality family time the parents are not spending with the child, that also puts more the child for depression, also leading to sleep related problems in children. And also a recent meta-analysis showed that less than 5 years of age had found an inverse association between the total daily screen time and the sleep duration. So response to the nighttime awakenings. In case the child has slept normally in the night but the child is having frequent nighttime awakenings, that is also a risk factor for sleep related problems in the children. Okay, when the child experiences nighttime awakenings, nowadays parents are have promoted the child to give mobile phones because they are lacking sleep. The parents are lacking sleep, so they give mobile phones so that the child goes earlier for sleeping. Or the child, for example, they give binge eating in the night so that the child will have an increased satiety. That satiety makes them full and also it gives them adequate amount of sleep. Okay, so this is also one of the unhealthy problems where the parents are nowadays doing so that the child can go for early bed. So let's move on. These are the things whatever we assess with the history taking. Next we'll move on to assessing the child with a sleep related disorder. The etiology of sleep related disorder in children is multifactorial, not alone a single factor, that is right from unhealthy hygienic habits, improper sleep hygiene, followed by improper dietary habits, inadequate rest in between, inadequate physical activity, and more of screen time has made the children to have more prone for sleep related disorders. So a detailed history is more important. Now you can start giving them recording the sleep diary. That is, for more than 2 weeks you have to follow up them with the sleep diary so that you can assess how is the nighttime awakenings, how is the sleep for the child in particular 2 weeks period. Okay, and then you can give them, after giving the sleep diary, you can give them a questionnaires. So initially for adolescent there are different set of questionnaires and for children it is different set of questionnaires. For you I have quoted one example is children's sleep habit questionnaire for children usually validated from 4 to 12 years of age. For the personal use it is free of cost. But for a commercial purpose or for research purpose, these should be validated and should be get permission from the particular set of the who has developed the tool. Okay, so there are 33 items in the children's sleep habits questionnaire, that it includes the academic performance, sleep problems, and also how is the screen time. Everything comes under this 33 items. Okay, and it is a 41 point cutoff scale. It's a 41 point cutoff scale. When compared to adolescent, it is only for 12 to 18 years where there is only 28 items and the adolescent can itself score the questionnaire. Okay, and they can give back to scores to you, and it is developed for self evaluation of the healthy teens. Okay, and the sites have been provided in this particular slide so that you can go and also see the questionnaires. Next, moving on to the screen test. Just these are screening tests who has come for the first time with the sleep related disorders to your OPD. Okay, for example, one particular questionnaire is a good questionnaire is Beers questionnaire, that is bedtime issues, excessive daytimes, awakenings and regularity and during the sleep, and also sleep related disorders. This is a particular screening tool which is used in pediatrics for initial assessment of the sleep related disorders. But with not alone the questionnaires we can rule out the sleep related disorders, but set of investigation is very important, because without investigation we can't proceed and we can brand the child with sleep related disorders, because it is only subjective assessment, but the objective assessment is only can be done with the help of investigations. Particularly the gold standard for sleep related disorders is polysomnography. Okay, polysomnography is the gold standard. I think so the previous classes would have covered you how to interpret and take the polysomnography and how to use the instrument for recording the sleep related disorders. Okay, so I'll proceed with the advanced diagnostic tools in sleep related disorders. One is the actigraphy monitoring. Actigraphy is nothing but a watch like thing which has been attached to the child during the sleep, so that the overall period of the sleep has been monitored in the children. Okay, and other one is the home sleep apnea testing, that is it's a modified polysomnography which can be used in home. It doesn't have multiple leads, only 2 or 3 leads has been used in the home, and the overall sleep activity is monitored for 24 hours, and it is brought again to the hospital to interpret the findings. Okay, and another one is the multiple sleep latency and maintenance of wakefulness testing, that is also modified polysomnography, but it is a stage 2 polysomnography or stage 3 polysomnography. And an advanced polysomnography, that is it is usually which has covers it has all advanced EEG leads along with EMG leads and also ocular leads. Okay, ocular leads and chin leads. This is the advanced polysomnography which gives a detailed description of the sleep pattern in the children, and it is not available in all hospitals in India. Only particular centers, sleep centers has these devices, and it is very costly, and also it is difficult to attach the leads to the children with the help because there will be multiple leads, so the child gets agitated, and we can't maintain that type of thing in children. Only in case of adults and adolescents we can do like that. But in India they have done in 3 years. The minimum age requirement for polysomnography, that is advanced polysomnography, is 3 years. Okay, so from 3 years they have done the studies. So let's move on to the sleep related problems. We initially assess the history of the child, followed by the assessment with the help of questionnaire and screening tools. Now moving on to the common sleep related problems in children. Let's see first the definitions of the common sleep related problems in children. So before going to the sleep definitions, let's classify broadly the child terms. Sleep related disorders. One is dysomnia, that is disorders of quantity or timing of sleep, that is insomnia and hypersomnia are the further group of dysomnias. While coming to the parasomnias, that is abnormal behavior during the sleep and wakefulness, this is the other type of sleep related disorder which is broadly classified, and it is very important because most of the common pediatric sleep related problems are parasomnias and also dysomnias. Okay, so dysomnia is mainly the quantity and timing of sleep disorders, while case of parasomnia is the abnormal behaviors during the transition of sleep and wakefulness. Okay, so these two terms is very important terms, and we have to classify the sleep related disorders based on this. Okay, so let's moving on to the definitions. Okay, so dysomnia, it is disorder or quantity or timing of sleep. Okay, they are further classified into insomnia, hypersomnias. Okay, insomnia, a perceived disturbance in the quantity or the quality of sleep which depending on the specific conditions, that is may be associated with the disturbance, and it is objectively measured sleep. Okay, so we can't say subjectively whether the child is saying I can't sleep, so that can't be taken as insomnia. But when we record the sleep patterns and we can say there is sleep and wakefulness in the child, and the quality and quantity of sleep has been disturbed in the child, we can term the child as insomnia. Okay, hypersomnia is the condition where there can be clinically expressed excessive sleepiness. Most probably the excessive sleepiness occurs in the daytime, because night time the child is active, the child is not sleeping, and they go for excessive daytime sleepiness, that is hypersomnia. Okay, When coming to parasomnia, it is entirely abnormal behavior that is between the transition between the sleepfulness and the wakefulness. Okay, they often reflect the appearance of the normal sleep process in inappropriate times, not the appropriate times. Okay, because the child will have a disturbed sleep pattern. This is the overall classification which I have explained you prior. Okay, that is dysomnia and parasomnias. Okay, we will be seeing the individual sleep related disorders, particularly one topic, and also I will be dealing the investigations and management related to the particular topic. Okay, let's move on to dysomnias first. So dysomnia, they are further classified into insomnia, hypersomnia, narcolepsy, breathing related disorders, and circadian rhythm disorders, and dyspnea not otherwise specified. Okay, so we will see individual dysomnias now. So dysomnia, I already previously told that it is a disorder of quantity and timing of the sleep. Okay, so the further classification is insomnia, hypersomnia, narcolepsy, breathing related sleep disorders, circadian rhythm related disorders, and dyspnea not otherwise specified. The dyspnea not otherwise specified cannot be classified under the one particular headings in these headings, and it is, we can take it as periodic limb movements, restless leg syndrome, and Klein-Levin syndrome. Okay, so let's moving on to the insomnia. Insomnia, we can take it as primary insomnia and secondary insomnias. The primary insomnia is due to the sleep problem itself, while the secondary insomnias maybe it can be lead to the any other systems that causes insomnia, particularly behavior problems, psychiatric problems, any excessive drug intake which can lead to secondary insomnias. Okay, so first we will deal with the primary insomnia. So the primary insomnia is difficulty in falling asleep or remaining asleep that lasts for at least 1 month. Okay, so the brief period we are taking it as 1 month. So it can be caused by the traumatic event, that is post traumatic stress disorder related to sleep or bedtime. Okay, and it is often associated with increased physical or psychological arousal at the night. And people who experience insomnias are often anxious, that is they have the secondary anxiety, okay, about not being able to sleep, and usually begins when the person is in young adult or adolescent stage or middle age. Okay, now it mostly not occurs with the infancy or in the toddlers. Okay, next moving on to the predisposing factors. The primary predisposing factor for insomnia are internal stress. Usually the adolescent and middle-aged persons will experience this stress, okay, because they will be having the hormonal change, also they will be having the physical change, and also they are more exposed to the society when compared to the others. So this itself will result in predisposing factor for insomnia. Okay, and this results in disruption to the hypothalamic pituitary adrenal axis, which results in hormonal imbalance and resulting in sleep wakefulness and also depression and anxiety. The other biological factors again I told is age, female gender who are more prone, and hyperarousal influences. So the diagnostic criteria for primary insomnia is the predominant complaint occurs should be at least for 1 month, and the sleep disturbances or associated daytime fatigue, usually clinically significant distress or impairment in the social, occupational or other important areas of functioning, that is either in the academic performance or in the social behavior or either in the occupation, that is in their jobs, when they have a distress which leads to improper sleep, will term it as insomnia. Okay, and the sleep disturbances does not occur exclusively during the course of narcolepsy or breathing related sleep disorders. They should not have any other sleep related disorders like narcolepsy, circadian rhythm disorders, or function of breathing disorders, or any other parasomnias. And the child should not have any other psychiatric illnesses also like general anxiety disorder or delirium. Okay, and the child should not take any substance abuse like drug abuse or alcohol abuse or any other abuses. The child should not undergo. Then only we can term the child as primary insomnia. Okay, so the treatment, the predominant treatment is non-pharmacological. We can go for maintaining the sleep hygiene, cognitive behavior therapy, then we can control the stimulus of the anxiety, then we can give some relaxation exercises or yoga. Okay, if it is not controlled with the non-pharmacological, we can go on with the pharmacological ideas, that is changing the diet, giving melatonin supplements, and I think so the pharmacological drug classes will be taken further in the further classes, or it will be covered previously. Okay, so melatonin, L-tryptophan can be given as substitute, short-acting benzodiazepines can be given, or Z drugs can be given like zolpidem, or low-dose sedative antidepressants can be given, that is mirtazapine, or longer-acting drugs like flurazepam, curazepam, and other drugs like nefazidone or quetiapine can be used in children also. But predominantly these drugs are more for adults, but for children only we go for non-pharmacological mediator, because with the stimuli itself the child can change. Okay, and early initiation of cognitive behavior therapy is the treatment of choice for most of the insomnias. Okay, and for chronic insomnias better go for non-pharmacological treatment. Okay, and always it should be a team management, not individual management. Sleep physician should be handling the cases along with a psychologist or a psychiatrist, and also along with the child nurse who has done a specialized course in this. Okay, so they can also come into play for maintaining or for treating the child. Okay, and use of pharmacological agents may also benefit, but most for the chronic cases only will be going for the, in case of children, for the insomnias. Okay, primary hypersomnia. Next, moving on to the second condition called hypersomnia, that is condition marked by excessive sleepiness during the daytimes or normal waking hours. The child will, the parents will be bringing you the child with the child when they wake up, they feel excessive daytime sleepiness. Okay, or after waking up itself the child is frequently yawning. Okay, and the patient has either lengthy episodes of daytime sleep or episodes of daytime excessive sleepiness, which is complained by the teacher. Okay, and in some cases the patient with primary hypersomnia may have difficulty in waking up from the morning sleep also. Okay, and may be confused or angry when we wake up them in the morning. Okay, from the bed, and the condition is always called sleep drunkenness, and it is more common in male children when compared to the females. Okay, and usually the young adults, that is from 15 to 30, they are most frequently affected with the hypersomnias because of their late time sleepiness, and also because of the explicit drug abuse or alcoholism or the smoking, which results in hypersomnias. Okay, and also caffeine intake, one of the most nowadays, all the young adults are gone for caffeine addicts. Okay, most of them drink coffee or tea, which results in hypersomnias. Moving on to the diagnostic criteria for hypersomnias. The predominant complaint is excessive sleepiness for at least 1 month or less if recurrent. Okay, and evidenced by prolonged sleep episodes or daytime sleepiness episodes, and poor academic performance, and the excessive sleepiness mostly causing significant distress towards the academic performance or to the social or to the occupational areas of functioning. Okay, similar to that of insomnia. And there should not be any other sleep related problems like narcolepsy, insomnia, or any other psychiatric issues, or any other case of physiological abuses like drug abuse. Okay, specify if recurrent. In case of recurrent hypersomnias, period of excessive sleepiness at least 3 days should be mentioned. Okay, occurring several times at least for 2 years period, then only you can say that child is having recurrent primary hypersomnia. Okay, so the treatment of choice would be modafinil or arundel. Okay, and dopamine reuptake inhibitors can be also used. Okay, sometimes non-sedative SSRIs and stimulant drugs can be used. Stimulant drugs are mostly second line drugs, and primarily we have to give cognitive behavioral therapy. Okay, so let's moving on to the narcolepsy, which is important. Okay, narcolepsy is characterized by recurrent sleep attacks in a patient. The patient cannot resist the sleep. Hence it is called sleep attacks or sleep terror. Okay, and the sleep attacks are about 10 to 20 minutes long, and it is only for a brief period, that to 10 to 20 minutes. Anything like any stimuli could result in narcolepsy. The patient feels refreshed by the sleep, but typically feels sleepy again several hours later. Okay, and about 40% of the patients with narcolepsy have or had other mental illness along with it. Okay, and 18% of the patients are 10 years or younger to that. Okay, and mostly our men and women are equally affected, and predominantly there are 3 symptoms, major symptoms, that is cataplexy, next is hallucinations, and sleep paralysis. Cataplexy is the sudden loss of muscle tone or stability, that is drop attacks, and hallucination, that is either it can be visual or auditory. Okay, or gustatory, it can be any type of hallucinations. Okay, And when the patient falls asleep, immediately they will have hallucinations and sleep paralysis, that is mostly occurs during the transition from being asleep to waking up stage. Okay. And the diagnostic criteria, let's move on to the diagnostic criteria. Irresistible attacks, that is refreshing sleep that at least lasting for at least 3 months. Okay. And presence of one or the more of the following, that is cataplexy, recurrent intrusions of the elements of the rapid eye movement sleep into transition between sleep and wakefulness, as manifested either by hypnopompic or hypognagic hallucinations or sleep paralysis at the beginning or end of the sleep episodes. Okay. And the disturbance is not due to the direct physiological effects of a substance abuse like drug abuse or any other medication abuse. Okay. So the treatment is follow up the routine bed care, don't change from the bed care habits, and have a good sleep hygiene. It should be a planned nap. Even though it's for a short duration, prepare a planned nap and avoid fatigue as it provokes catalepsy. Okay. And the medicines used are dexamethasone, okay, modafinil and methylphenidate. Okay, that is Ritalin. Okay. And for catalepsy, you can use tricyclic antidepressants or selective serotonin reuptake inhibitors. For sleep related breathing disorders, this is another set of sleep related disorders which comes under dysomnias. Okay. The predominant is the where the brain is affected predominantly, okay, rather than something else. Predominantly there are risk factors for this. Most probably sleep apneas come under sleep related breathing disorders. Mainly this apnea means any cessation of breathing for more than 20 seconds. Okay. But in case of sleep apneas, in case of adults and adolescents and children, they will be having a brief episodes of apnea with hypapneas. Okay. So mostly the diagnostic criteria will be based on apnea and hypapnea index. Okay. And predominantly the adult apneas and hypapneas are something different when compared to the pediatrics. And the pediatrics has different criteria in case of OSA or in case of central apnea or in case of mixed apneas. Okay. Let's see the obstructive sleep apnea. In case of children, the obstructive sleep apnea, again like in case of adults, it is mostly due to obesity and adenotonsillitis. These are the two predominant indications for the child to develop an obstructive sleep apnea, and around 80% of the adolescent and obesity results in obstructive sleep apnea. Okay. And snoring is the predominant complaint, and there will be frequent awakenings in the night followed by daytime sleepiness. Okay. In case of obstructive sleep apnea. So the etiology is, as I said, it is obesity, excessive soft tissue in the upper airway or decreased upper airway lumen size or failure of the pharyngeal wall dilated muscles, that is constrictor of the pharyngeus muscles. Okay. And however in children the obstruction is primarily due to the enlarged tonsils or the adenoids. So nowadays the obstructive sleep apnea is diagnosed non-invasively with the help of nasal diagnostic endoscopy. This is the investigation of choice rather than polysomnography nowadays. Let us take it as a screening, but the gold standard is always polysomnography. But we can take it as predominant investigation or primordial or primary investigation which has been done to rule out the obstructive sleep apnea in children. Okay. And the prevalence is 1 to 5% in 2 to 8 years of age, and most probably males and females are more equally affected and more common in blacks because they have frequent craniofacial problems. Okay. And also these are more common in neuromuscular diseases, choanal atresia patients. Okay. And also in muscular dystrophy patients. So there are neuromuscular disorders will have predominant obstructive sleep apneas and mixed apneas when compared to central apneas. The clinical presentation will be snoring, sleep-related paroxysmal breathing, nighttime enuresis, diaphoresis, morning headaches, cognitive behavioral issues like depressed mood in the mornings, or poor concentration in the school, attention deficit in the school, excessive daytime sleepiness, or enlarged tonsils or adenoids resulting in frequent URIs and LRIs. Okay. And also pectus excavatum. So the diagnosis is predominantly with the help of polysomnography, where we will find apnea and hypapnea index. Okay. And apnea and hypapnea index should be greater than 1.5 per hour in case of children. It is not for adults, this is for children. Okay. And treatment first line should be adenotonsillectomy because most common cause is adenotonsillitis. Okay. And also in case the parents are not willing for surgical management, we can give other modalities like continuous positive airway, CPAP, as the primary mode of treatment in these children. Okay, CPAP would definitely help, or BiPAP. Okay, both CPAP and BiPAP has equal effectiveness in case of obstructive sleep apnea in children. Okay, and also some prosthetic devices or the orthodontic devices which can widen the upper airway so that there won't be any obstruction in the children. Okay. So central sleep apnea. Let's move on to the next topic, central sleep apnea. That is, it is the reduced or absent respiratory effect in children because of the diminished airflow, which results in diminished airflow and absent intermittent or cyclical fashion of the breathing. Okay. So here the apnea and hypopnea index should be more than 5, and it is always associated with signs and symptoms of sleepiness or sleep disturbances or awakenings or short-term breath or snoring and apnea. The primary central sleep apnea, the etiology is remaining unknown. Okay, it is mostly due to secondary and other disorders like other sleep related disorders or hypoventilation disorders and hypoxemia disorders. That is, in hypoventilation disorders there will be elevated levels of PCO2 in ABG, and there will be hypercarbia in case of ABG also. Okay, and hypoxemia related disorders, there is sustained drop in arterial O2, mostly in who are residing in the mountain or who are living nearby seas. They will be having these types of disorders. Okay, or who are frequent divers, they will also have hypoventilation or hypoxemia disorders. Okay, so now moving on with the parasomnias. So parasomnias, they are broadly classified as nightmares, sleepwalking, sleep terror, and parasomnia not otherwise specified. Parasomnia is abnormal behavior, experiential or physiological events occurring in association with sleep or sleep-wake transitions. Usually the motor activity is complex here, and it is always related with the sleep related problems. Okay, and most of the times it is often associated with the non-REM sleep and sometimes with the REM sleep also. Okay, and moving on to the non-REM parasomnias, these are more frequent in children, that is sleepwalking or somnambulism, sleep terrors and night terrors, and sleep related eating problems. Okay, and sleep related eating problems, recurrent eating or drinking episodes during partial arousal from the sleep. It is uncontrollable and it is often associated with potential injury or aspirations, and the child will have a limited recall what he has eaten in the night or awareness. Okay, next moving on to sleepwalking. It is mostly prevalent in children, that is 17%, and 4% only in adults, most common in males, and family history of sleepwalking should be present. That one parent is 45% risk and two parents 60% risk for the child to develop somnambulism. Usually occurs during the first half of the sleep period, not in the second half, that is in the first half itself. And that child won't have the memory of the event, and the predominant diagnosis made with the history only and not with the polysomnography. Okay, and the diagnostic criteria is same whatever I told previously. The child will have the awakening only in the first period of the sleep duration and repeated episodes in the night during the sleep and walk, and the child will have predominant walking about, usually occurring during the first third of the major sleep episode. Okay, and while sleepwalking the patient remains blank, he doesn't remember, the memory is not intact during the sleepwalking, and the sleepwalking should significantly have the distress or impairment in their social or occupational or any other important areas of functioning, and it should not be due to either physiological effects of the substance abuse or drug abuse or caffeine intake. Okay, and the treatment is reassurance and also increase the total sleep time. Okay, and hypnosis and scheduled awakenings, that is 15 to 30 minutes before the episode, will help the children to prevent the further episodes of sleepwalking. Benzodiazepines can be used and tricyclic antidepressants also can be used here. Okay, and most preferably the acute stress should be relieved from the child. Next, moving on to the confusional arousals. It is 17.3% in 3 to 13 years old and 2.9 to 4.2% in those older than 15 years. Usually both are equally affected, that is male and females. This is confusional arousals are often termed as sleep drunkenness. Okay, and inappropriate child behavior which is resulting in slowed responsiveness and also slurred speech and confusion after awakening. Okay, it is always diagnosed with the polysomnography, and reassurance is only the treatment of choice, and cognitive behavior therapy can also be done. Okay, and sleep terrors, it is 1 to 6 occurs in 1 to 6% of the children, and usually the age of onset is 4 to 8 years of age. Here there is no gender difference. Okay, the child may sit up suddenly and scream with blood-curdling battle cry, that is intense fear, screaming, crying and confusion, and this is accompanied by apparent autonomic activation including mydriasis, tachycardia and also diaphoresis. Predominantly this occurs in children, and hence the parents bring them with disturbed sleep in OPDs. Okay, sleep terrors are the most common when compared to any other disorder in sleep. Okay, the event may last for a few minutes up to maximum of 20 minutes period, and then the child will have insomnias followed by. Okay, the diagnostic criteria is recurrent episodes of abrupt awakenings from the sleep, intense fear, relative unresponsiveness, no detailed dream is recalled, the child couldn't recall the event, and also there should not be any other mental illness in the child, and there should not be any substance abuse in the child, and also the child should have the the child should have a disturbed occupational, social or other important areas of functioning abnormalities. Okay, and it is diagnosed only by history. PSG is not required here also, that is polysomnography. Reassurance and increased total sleep time, scheduled awakenings and bedroom and home safety is very important here. The child should not have, the environment for sleep should be maintained, there should not be loud noises, and sleeping environment should be peaceful. Now, not bright sounds or bright light should be in the room, or not bright painting should be in the room, or even the disturbing pictures like this. Okay, nightmares, it is 10 to 50% in 3 to 5 years old, and it occurs between 3 to 6 years. Here the genders are equally affected, and unpleasant dreams, this should be differentiated from sleep terrors. Okay, because nightmares usually the children, it can be physiological also. Okay, and it can be diagnosed only with a history, and reassurance is the treatment. Okay, let's moving on to the sleep paralysis. It's the inability to perform voluntary movements during the transition between sleep and wakefulness, either at the sleep onset or during awakenings, accompanied by extreme fear. Okay, so daytime sleepiness, it is a secondary symptom, not the primary sleep related disorder. Okay, and it is often accompanied by narcolepsy or obstructive sleep apnea in children, and periodic limb movements. Let's move on to parasomnias not otherwise specified. One is the bruxism, that is grinding of teeth throughout the night, and most probably that there will be a dental bite plate or corrective orthodontic procedures has been done previously, so that the child will have sleep related bruxism. And REM sleep behavior disorders, it is very rare in children, only it occurs in adult and adolescents. Here the child will have complex, often violent behaviors in the sleep. Okay, and sleep talking, most of the child will have physiological sleep talking, and it involves few words, and only because of the inappropriate sleep hygiene previously followed. Okay, so the child will have sleep talking, and sleep related head banging also sometimes can be associated with that also. Okay, and here only the behavior modification therapy, reassurance to the parents must be maintained here. Okay, and circadian sleep rhythm sleep related disorders, it is seen with adolescents and adults, that is it is the frequent jet lag type. Usually the parents will go for foreign, after that they bring the child here to particularly, so for a brief period, so the child will have a jet lag. Okay, so the child can't sleep, only it can be accustomed to that particular country, and it will require time for the child to adjust. Okay, and another one is delayed sleep phase type. Here the later appearance of sleep but is normal total sleep time, that is usually the child sleeps at 1 or 2, and in the morning also it wakes up late. This is a delayed sleep phase type. And shift work type, usually parents have shift work, so they make the child also sleep along with them in the late nights. Okay, this is also different type of, this is also all related to the circadian rhythm related sleep disorders. Okay, so let's move on to restless leg syndrome. It is an unpleasant sensation in the legs with the urge to move the legs in night. Mostly it occurs in the evening sleep, and also the rest worsens symptoms and movement provides some relief. Okay, if the child keeps on maintaining one posture, the child will have restless leg syndrome. The child will have excruciating pain in the night and symptoms similar to those with the attention deficit hyperactive disorder. Okay, here main thing is dopamine dysfunction, genetics and iron deficiency, which plays a predominant role in restless leg syndrome. So the treatment of choice would be reassurance and also iron therapy in children. Okay, so 50 micrograms per liter can be given in children who is having restless leg syndrome, and it can be diagnosed with the help of polysomnography. Okay, and drugs can be used. Other drugs are dopaminergic medications, can be used as first treatment of choice, and carbidopa, levodopa can also be used. Okay, other drugs rarely used are clonidine, clonazepam or gabapentin. Periodic leg movements, it is called nocturnal myoclonus, mostly stereotyped with abrupt contractions of certain leg muscles, mostly calf muscles. Okay, the patient remains unaware, but usually it can be recorded with the help of polysomnography. It can also result in daytime excessive sleepiness. Main treatment of choice would be benzodiazepines and levodopa, and TCA would exacerbate this condition. Okay, that is tricyclic antidepressants. And behavior related insomnia, as previously mentioned, the child will have some rocking movements, TV or usage of mobile phones, tablets, okay, and some behavior problem like the child should have a feeding bottle before going to bed or nail biting before going to bed. These are the abnormal behavioral problems which results in insomnias, okay. And limit setting disorders, that child repeatedly refuses to go to sleep at bedtime and parents allow them to stay long, because in the IT professionals the parents will have laptops or they'll have jobs till 1 o'clock in the night, so they make the child also sleep at 1 o'clock in the night. This is called limiting setting disorder, okay. And also feeding related disorders, usually late night feedings like 10 o'clock, 11 o'clock, they take them outside, they feed the child, which results in abnormal behavior and also results in insomnias in children, okay. The psychiatric causes, whatever we talk is, that is post traumatic stress related disorder, child abuse, anxiety, depression or mood related disorders. This results in secondary insomnias to the children, okay. It is not the primary cause, it is the secondary insomnias, okay. And medical causes like colic pain, infant colics can also result in delayed sleep in children, and medication side effects like cough syrups, antibiotics, sedatives, steroids, these also causes delayed sleep or sleep related problems in children, okay. And sleep hygiene, last but not the least, everyone should maintain the sleep hygiene for the pediatric sleep related disorders or child related sleep related disorders or infant child related sleep disorders, okay. Sleep hygiene is an important thing. Parents nowadays are missing sleep hygiene, unlike personal hygiene, so sleep hygiene should be maintained. I will give a set of things to maintain sleep hygiene, okay. These are the tips. One is get regular sleep, that is bed and wake up time should be maintained. Sleep when the sleepy, make the child sleep when the child is feeling sleepy and sleep along with them, okay. Make a pleasant environment, get up and try again, that is when the child gets up, ask them to sleep again, okay. Don't make them get up and go for some other activities, okay. Avoid caffeine in children, also nicotine in case of adolescents. Bed is only for sleeping, not for mobile devices or for reading, okay. No naps at school or work, because nowadays in school they are asking the child, that is toddlers, to sleep in the school. No naps at work or school should be maintained. And sleep rituals, nowadays there are pleasant music which can be played in the room or pleasant lights which can be played in the room, like a space effect you can give for the sleep ritual for the children, okay. And you can give bath before going to the bed. The hot water bath will promote sleep in children, okay. And don't place clocks in children, because clock can disturb sleep in children. Don't set alarms for the children, okay. Use a sleep diary and also ask the child to do exercise or yoga before going to sleep. Eating right, also giving them a right space, also maintaining a daytime routine will help to maintain the sleep in night, okay. And dark, cool and quiet environment is necessary for all the children, okay. So thanks everyone for giving me this opportunity and not for sleeping in the class. So this is the end of the class. Thank you.